Good afternoon to all. On behalf of BCIP, I would like to welcome you all for joining us for today's webinar. I am Himanshi, a student of BPT 4th year of Vanasidas Chandiwala Institute of Physiotherapy. I would like to thank the whole team of BCIP for conducting such an information session and giving us the opportunity to enhance our knowledge. Today, we have our eminent speaker, Dr. Devyani Thakre, with us to enlighten to all. On behalf of BCIT, I would like to welcome you all for joining us for today's webinar. I am Himanshi, a student of BPT 4th year of Vanasidas Chandiwala. Today, we have our eminent speaker, Dr. Devyani Thakre, with us to enlighten on the topic role of physiotherapy in breast cancer rehabilitation. Dr. Devyani Thakre is a physiotherapist and a cardiovascular and pulmonary physiotherapist in Nagpur and has an experience of 9 years in these fields. Dr. Devyani Thakre practices at Pro Clinica in Nagpur. She completed BPT from Ravi Shankar Shukla University, Raipur in 2008, and MPT from Indore Institute of Medical Science. She is a member of Indian Association of Physiotherapists. Now I would request Dr. Devyani ma'am to take over the session. Hand over to you, Devyani ma'am. Welcome, ma'am.
Thank you so much. Thank you so much for that brief introduction. Hello, everyone. I'm Dr. Devyani Thakre. I am an oncology physiotherapist, and I'm so much thankful to Vanasidas Chandiwala Institute for organizing this webinar on this occasion. It's an immense pleasure for me to share the bit of knowledge I have with you all, and I hope that helps you all in growing our profession together. I would like to share my screen now. Is my screen visible?
Yes, ma'am.
Anywhere in between, if I'm not audible, please interrupt me. I would request the organizers for that.
Yeah, ma'am,
Okay.
sure.
So today's topic of presentation, today's topic of our webinar is role of physiotherapy in breast cancer rehabilitation. I have been in breast cancer rehabilitation since 5 to 7 years now, and a lot of experience with other cancer patients too. On this occasion of World Cancer Day, where everywhere there is a lot of awareness, it's very much required for we physiotherapists to know what we can do and how we can do in the oncology and in the cancer field. So I'm Dr. Devyani Thakre. I am Master's in Cardiorespiratory Sciences. I'm a certified lymphedema therapist from USA and also a certified therapist, breast cancer rehabilitation therapist. So coming forward with our webinar. So what is cancer? Everyone knows what is cancer, but I'll just explain it in a very simple form that it is an uncontrollable multiplication or division of the body cells which destroy the body. So it's our own cells which get on multiplied uncontrollably and form a tumor or kind of more cells than the usual number, and then that destroys our own body. It has definitely a big impact on the quality of life. Coming to the specific breast cancer. Now, what is breast cancer? Obviously, when there are uncontrollable growth of the cells in the breast tissue, it is known as breast cancer, which is seen in females and also seen in males. So it has a big impact on the quality of life. According to this research published in the Journal of Indian Journal of Cancer in 2020, it was said that the musculoskeletal dysfunctions after breast cancer therapies are range from 30 to 50%. That is a big number, 30 to 50%. Then various breast cancer treatments, I will just fast forward it because we all know there are a lot of breast cancer treatments, right from the surgery to the chemotherapy to the radiotherapy. So the breast cancer treatments, coming to the first part, the surgery. There are various kind of surgeries according to the growth of the tissue. One is the lumpectomy, where just the tumor is taken off. Just the tumor is taken off and there is a small incision. It's not a big incision. Then there is second type, which is the wide excision. In this, a lot of breast tissue is taken, but it's not radical mastectomy or modified radical mastectomy. The wide incision, the tumor size is pretty big. Tumor size is pretty big, and most of the time with the wide excision, the axillary clearance is done. That means the lymph nodes from the axilla are taken off, which is not usually done with the lumpectomy. And the wide excision, the whole axilla is cleared up a lot of times, but in lumpectomy, a few lymph nodes may be removed. Coming to the third and most common thing, which we all see in our clinical practices, is modified radical mastectomy, where the whole breast is removed. The pectoralis is spared. That is the reason why it is known as the modified radical mastectomy. Coming to the lymph node dissection. When we look about the lymph node dissection, there are various levels of lymph nodes, and we as a physio it's very important for us to know which level lymph nodes are removed. This is very important for us, and that's why I always suggest to go through the surgical notes of the surgeon, because they very clearly mention which lymph nodes are removed. Why is this lymph node removal number and the level important to us? Because most of the time there is a 40 to 60% of chances of a breast cancer after radical mastectomy, modified radical mastectomy, that they develop lymphedema. That is a swelling of the hand of that particular area. And now you want to treat lymphedema, it's very important to know which area lymph nodes are removed and which are available for you. So in this diagram, we can see there are 3 levels of lymph nodes: level 1, level 2, and level 3. The level 1 lymph nodes are on the axillary region. The level 2 are the intrapectoral group of lymph nodes, in the sense the pectoralis major and the pectoralis minor. These are in between these two. There are lymph nodes in between these two. These are level 2 lymph nodes. And level 3 lymph nodes are the infraclavicular group of lymph nodes. And most of the time they will find that level 2 clearance, level 3 clearance. If it is level 3 clearance, that means all up to from level 1 to level 3, a lot of clearance is being done. So a lot of lymph nodes have been removed from the patient's body. There is one more surgery, that after radical mastectomy, there is reconstruction surgeries, and we physio play a very important role in these reconstruction surgeries. Now, these reconstruction surgeries, they are mostly done by the cosmetological department, I mean the plastic surgery department, and the plastic surgeons are very precise about the contour and the shape and everything. So here our role is a little bit different. I'll just explain the procedure of this reconstruction surgeries. Most of the time, the internal implants are placed inside the tissue, but before placing the internal implants, they have a tissue expander. They place tissue expanders. Like during the surgery, after intraoperatively, what they do is they just place a silicone pouch or a saline water pouch inside the tissue, breast tissue, which is already removed. I mean, the fascia and the skin, the pectoralis major, beneath the pectoralis major, this tissue expander is placed, and it is kept there for weeks to months so that the tissue expands. Then another surgery for an implant is done. So, the tissue needs to be expanded. Pectoralis muscle is also involved in this, the major muscle. So a lot of things to be done as a physio. Now, just imagine, like we are giving some shoulder or range of motion exercises. for a person who already has a tissue expander in their C2. And now I'm going for above 90 degree of movement. All my breast tissues, the pectoral tissues, the fascia is moving upward. And then there will be a derangement or malalignment in the breast tissue, which obviously the plastic surgeon won't encourage at all. So you need to be very, very precise while doing physiotherapy in breast cancer, and physiotherapy in reconstruction is equally important, just that the little bit delayed process is there, and you need to be in very good contact with your plastic surgeon as in what he wants and how to move ahead with it. Another part of reconstruction is flap surgeries. In this, the flap of the skin flap from the patient's body itself is taken and the tissue is reconstructed. So here the physiotherapy role are divided into two parts. That is the recipient side and the donor side physiotherapy. If the latissimus part is taken for the reconstruction, then we as a physio, we need to rehab the latissimus part as well as the shoulder and the breast tissue and the chest complex too. So we have two sides to work on, that is the recipient side and the donor side as well. Now, one more therapy which is there in the breast cancer package is radiation therapy. Now, in this, there are there is a radiation which is bombarded on the tissue, and I'll tell you that these radiations, they penetrate from one side and they come out of the other side of the body. So everything which comes in its way is exposed to that radiation. For example, if in this breast cancer patient, if the radiation is being bombarded on this side of the breast, then it will penetrate from the other side of the body and come out from there. So it has all the tissues involved in it, right from the lungs, everything. So as a physio, you have to know how many radiations have been done, how is the impact of the radiation, and then you will have to move ahead with all the rehab, including the respiratory rehab for these patients. So this is important, although the impact is more on the superficial side, I mean the near to the projector, but it does involve the whole tissue inside. One more thing which happens with radiation therapy, as you can see in the second picture, this is 24 months post radiotherapy skin. It still has a lot of fibrosis. When I say fibrosis, it means the musculocutaneous tissue is very much tightened. It becomes a hard tissue. That's known as radiation fibrosis, as you can see in this picture here, the second picture. It is a clinical picture. This is 24 months after radiation therapy. That means 2 years after radiation therapy, and still the patient is having a lot of fibrosis, which can affect her range of motion of the shoulder, can create a lot of back issues. Even the sternocleidomastoid muscles may be, they may get malaligned because of these fibrosis and biomechanical impairments. Coming to the musculoskeletal issues, what we physios always are, that's our main domain, which usually have it. It is more common after modified vesical mastectomy, and less common after the wide excisions, and even less common with the lumpectomies. So what happens in these musculoskeletal issues, our treatment, what we can do in these musculoskeletal issues is we have a zone of shoulder range motion restriction. That is the range of motion at the shoulder joint of the operated side is a lot of restricted because the patient is afraid to move on. And there is some restriction in the shoulder ranges in the initial days because of the drain in C2, also the suture line and everything. Another concept is the shoulder arm pain. Now it is different than a frozen shoulder. It is a movement restricted pain scenario where the shoulder is not frozen. There is no adhesive capsulitis, but there is pain restricted movement, which may be because of some muscle tightness or just an inflammatory response beneath the tissue. Yes, posture and scapula positioning is very important. The nerve that supplies the serratus anterior is the surgeon preserves that nerve definitely, but while lifting that nerve during the surgery process, the sheath is a little bit sometimes the sheath is a little bit injured, the nerve sheath, and that leads to some kind of weakness in that particular posture. In that particular muscle, you can see little winging of the patient, and obviously then we'll have to reposition and train the serratus anterior, the latissimus dorsi to reposition the scapulae in their position. Posture is very important. These ladies, they tend to bend to the side of the incision or a little kyphotic posture. Long-term posture derangements will lead to other musculoskeletal issues. So posture awareness and posture training is very important right from the day of surgery. Even I will suggest pre-operatively, the patient should be educated for it. So obviously a pre-operative physiotherapy call for these patients is very, very important. Another thing is the breast cancer related lymphedema. It is altogether a different entity, a huge concept, but just to introduce to it, because the lymph nodes are removed of that side, then there will be edema developing. And this edema is like once the patient develops this edema, you cannot revert it, you cannot treat it completely like that, but you can manage it. That means, yeah, it's like diabetes, you can say. If you continue doing exercises and all, your diabetic will be controlled. If you continue doing your therapy with the breast cancer, I mean the complete decongestive therapy, the lymphedema, the swelling will be controlled. So that is how we tell the patient that you can manage lymphedema. Now, this is very important because scapular kinematics have found to be drastically altered with mastectomy cases. This was a study published in 2012, and it shows that it was done in the breast cancer survivors, and it was seen that the shoulders and scapular kinematics are highly altered in mastectomy cases bilaterally, even when the patient has no complaint, no pain. The shoulder comorbidities are seen up to 6 years after surgery. See, this is very different from any kind of orthopedic surgery related to shoulder joint, because the comorbidities followed by the orthopedic surgeries of shoulder joint, they have a span of around 12 to 24 months. But here, it's found that it's seen for 6 years as well. So even the patient is in remission, that she's not having cancer now, but still she can have these kind of shoulder and scapular dysfunctions. So it's very important to keep in our mind that even 6 years, it's possible for her to have a frozen shoulder. It's possible to have a neck shoulder syndrome or even the cervical issues. So this is something very important, the 6 year span, which is found in various studies, an average of 6 years. Other musculoskeletal issues includes muscle tightness, as I told, the pectoralis minor, the pectoralis major, the sternocleidomastoid tightness, neck pains. Yes, there are because of all these arrangements. There are upper thoracic back pains because of the paraspinal muscles spasms, as the patient is used to in a very kyphotic posture, or they are not using their scapular retractors properly. Upper limb surgeries and other invasive procedures. If the patient has undergone any kind of upper limb surgery on that particular side, then your role is drastically increased, because he or that person, that she is not having lymph nodes, another trauma on that particular side, for example, a trauma, fracture, and she has undergone a surgery. Now, there are very high chances for her to develop swelling. You have to treat two things: the range of motion, the fracture, the orthopedic rehabilitation, also the lymphedema management. You have to do hand in hand together. Yes, there is one more thing. This is, as you can see, this is a port. This is a port of chemotherapy, in which the chemotherapy drugs are directly put inside by this port in the central line. And this port restricts some range of motions in many patients. So the patients won't tend to move. This port is there for months. I mean, it can be there for weeks and months. So the patient's range of motion are restricted. As a physiotherapist, you have to encourage the range of motion of the patient and ask her to do the range of motions even with the port, just making sure that you don't harm or kink the port lines. Coming to the musculocutaneous issues. Now we were talking about musculoskeletal issues. Now I'm coming to the musculocutaneous issues. This is very important. Seroma. Seroma is an abnormal collection of pouch of fluid which develops near the surgical site. I have seen a balloon sort of seroma collection or fluid collection, which is equal to the other breast. The breast was removed and there was so much of collection that it was found that another breast is coming up. So that can be an issue, because those who have seroma, they have a higher risk of lymphedema, and lymphedema is a lifetime thing. And we physio have a role to play in seroma because there are certain studies which have shown that if we do excessive movements in the initial 2 to 3 weeks of the surgery, excessive stretching and movements in the initial 2 to 3 weeks of surgery, there are more chances for us that we can develop seroma in these patients. So when we do active range of or active assisted range of motion exercises, just make sure that we are not causing any seroma. This is because when the MRM is done, the modified radical mastectomy is done, the fascia over the pectoralis major, the surgeon has to remove that fascia or get access to that tissue via the fascia, and that fascia takes time. So if we are moving continuously in extreme range of motions, we don't give the fascia to time to heal, and it will lead to some extracellular fluid accumulation leading to seroma. Now, this seroma, the patient will have to go again and drain it up. Plus, it adds on an infection risk. Also, it adds on to the lymphedema risk. Skin conditions, yes, during the therapy, there can be a lot of skin conditions. You need to check the skin because any kind of trauma because of dryness or infection in the skin will increase your complications during the treatment, during the physiotherapy management. Axillary web syndrome or cording. This is in this photo, as you can see. There is a tight band sort of thing. If you can see in the axilla as well as near the elbow, there are 3 bands. These usually are mistaken by the therapist with tendon or muscle tightness. These are not muscle tightness. This is cording, which is the lymphatic vessel which has become thickened, and there is a lot of clogging of lymphatic fluid inside it. So you need to do a good manual lymphatic drainage properly, no massage. Manual lymphatic drainage is very different from massage. If any of the medical professional or even the patient asks you for massage, massage is totally contraindicated even in the lymphedema patients because that will increase lymphedema. Some other musculocutaneous issues are these scar tissue adhesions, which will lead to range of motion restrictions and pain. And yes, sensations, all the female patients will tell you that I don't get sensations here. It's numbness or it's some kind of tingling. That's okay. That's okay because during the surgery, a lot of sensory nerves are incised and they don't develop again. So a little bit of sensory issues is there in all the females, nearly all the females. And one more thing with the sensation part, if you are applying anything in the back region for back pains or something, any kind of heating cold or something like that, which is not an absolute contraindication if the patient is in remission. But if you're applying something, you need to know the sensations because these people lack sensation in this zone, in the lateral truncal zone and a little bit posterior zone as well. Okay, another therapy is chemotherapy. A lot of toxic chemotoxin drugs are induced, injected in the body so that they can kill those cancer cells and retard their growth. These chemotherapy drugs have a lot of side effects in many patients. The newer drugs have less side effects though, but still the side effects are seen. Moreover, these side effects lead to psycho-emotional elements in the female. They lose their hair, they feel fatigue, there is a lot of weight loss, their skin becomes darkened, their nails become darkened. So there is a lot of psycho-emotional element involved apart from the chemotherapy problems. The chemotherapy has its own different problems which we'll be discussing and how we can help in that. So whenever treating a breast cancer patient, you need to understand there is a lot of psycho-emotional element attached to it because of these things. Moreover, in the later stages, a lot of patients are on hormonal therapy, which leads to anxiety, depression, and a lot of psycho-emotional problems. Also, the body image. This is very important. Though the female may not tell, but she is little bit skeptical about the body image. So we as a physiotherapist, we play a role of a physiotherapist, we play a role of a psychologist, we play a role of a friend, and because these patients, we are the luckiest one because the patients, they are more near us than the surgeon. So we are the luckiest one. We spend a lot of time with these patients, more than anyone else can, and the sessions we give are long-term sessions, multiple sessions. So we get a good arena to know the patient completely. It's very important to have this aspect. Immunotherapy is one of the other treatment which is given for breast cancer treatment. Very important, being a physiotherapist, what factors you need to assess before starting the rehabilitation or physiotherapy protocol. Lymph edema. Every female who has undergone a radical mastectomy or lymph node dissection has a high risk of lymphedema, even if it's not visible swelling. Now, in this case, this was my patient. She has a lot of edema here, which is very much visible, but not edema. Not all edemas are this much visible. The patient may just complain you of little bit heaviness. That heaviness is one of the symptoms for lymphedema. So you should not neglect that. That is itself is stage one. Little bit of heaviness itself is a stage one, even if you don't get any dimension change in the hands. Okay, now when the patients is referred to, usually when the patients are referred to our department of physiotherapy, or when they should be referred to the department of physiotherapy, first and foremost, every patient should go for a pre-operatively physiotherapy assessment to know how the patient is, what are the initial dimensions, what are the postural problems already existing with the patient, which can be aggravated afterwards, so that we have a listing of it and we can introduce some of the exercises to manage these things pre-operatively, same to what we do in our total knee replacements and other kind of surgeries. So yes, pre-operative physiotherapy call is very important. That helps a lot, because the patient is prepared, she's educated for that, she knows what to do, and even our mode of way of treatment after the surgery becomes very easy and very precise. Another department reference is palliative cancer rehabilitation. Now, what is palliative cancer care? Palliative cancer is the end of life care. I mean, the cancer is a little bit more widespread, and the patient may not have a huge lifespan, maybe a month, 2 months, 3 months. But now with palliative cancer rehabilitation, the main problem is a lot of pain is there. Now, in this case, they are in the end of life. A lot of analgesics are given, but yes, we have a role to play in this. I am attached to a palliative care center as well, where the patients are there for a week. They survive for a week, for a month or so, and they suffer from a lot of pain. The only thing is pain. So we as a physio have a very important role in pain. We can give a little bit of myofascial releases, taping, kinesiology tapings, which really helps in giving a better sleep to them, manual lymphatic drainages in palliative care, because see, the lifespan is already reduced, so you need to do something to make the patient's pain go off for those specific days. Now then, another, when the patients are referred, are during the neoadjuvant therapy. Now, what is neoadjuvant therapy? Neoadjuvant therapy is the chemotherapy and radiotherapy which is given pre-operatively. This is the neoadjuvant therapy pre-operatively. So when the patient are referred for chemotherapy and radiotherapy pre-operatively, again our role comes in, because the radiation may cause a lot of range of motion restriction. Chemotherapy pre-operatively will cause a lot of cardiotoxicity, neurotoxicity, wherein the patient will develop peripheral neuropathies, balance difficulties, low endurance. So, when we give a neurological rehabilitation along with the onco rehabilitation, that helps the patient to cope up all the chemotherapy and radiotherapy sessions easily and comfortably. Yes, we have a role in after surgery. That means immediately after surgery to a long term after surgery. Then during the adjuvant therapy, that is after the surgery or the chemo and radio is given, we play a very important role in that. Throughout the survivorship, yes, because see, 6 years, there is a high risk of comorbidities. Then there is a lifetime risk of developing lymphedema. So throughout the survivorship of these patients, we play a very important role. And these patients all the time mostly are referred to us for pain management, restriction management, that is the range of motion management, and secondly, lymphedema management. Oh, now the challenges what all the physios face. Why, what, when, where, now, whether electrotherapy, exercise therapy, electrotherapy is contraindicated, what kind of exercises, all the electrotherapy modalities are contraindicated. Now what to do? Because lymphedema will increase with heating, even if the patient is in remission, even if the PET scan is clear, And obviously, if you're doubtful about the metastasis, we don't go for any kind of thing which increases the lymphatic flow or the blood supply. So this is a big thing. I usually do not use any kind of electrotherapeutic modalities for my cancer patients. It's mostly the electrotherapy and the manual lymphatic drainages what we use. Manual lymphatic drainages ease the pain. This is proven. So proper manual lymphatic drainage, not massage, not effleurage, nothing like that. Manual lymphatic drainage is very different than the effleurage or other kind of massages we do. So it's manual lymphatic drainage which is going to help to ease the pains of the patient. And yes, exercise therapy, a lot of exercise therapy, but some quick picks, that is soft tissue techniques are very, very useful in increasing the range of motion. Manual lymphatic drainage, as I said, obviously. Kinesiology taping, decongestive exercises is a different group of exercise which improves the range of motion as well, and helps controlling the lymphedema. It usually involves a lot of pumping movements in the anti-gravity positions. So you can check out the position what the patient can go and give a lot of pumping movements in that position. Those are decongestive exercises. It's a huge group of exercises. And with the tissue expanders, yes, you have to be very, very precautious with the tissue expanders, considering your plastic therapist, your plastic surgeon is very, very important with tissue expanders. Alert, alert, alert. When what we do during muscle stretching, capsular stretches, yes, you can give it, but a little bit alert. You should not go in the range where you damage the tissue and lead to a lot of vasodilation. You will present the patient with lymphedema, which she never had. So any kind of extreme tissue stretch, extreme muscle stretchings will lead to seromas, will lead to lymphedema. So gentle passive movement, active assisted movement, active range of motion exercises are the best in these cases. Yes, alert again, joint mobilizations. For example, a patient is coming for a shoulder restriction and we need to give some mobilization techniques. Yes, you can give mobilization techniques, but grade 3, grade 4, grade 5, I mean the manipulation techniques, they increase the blood circulation if you see the physiology of mobilization. So it's recommended grade 1 and grade 2 mobilizations to be done in this patient. So gentle grade 1 and grade 2 mobilizations. Yes, physiotherapy during adjuvant therapy, chemotherapy affects the nerves, it affects the respiratory system, it affects the cardiac system. Certain drugs are cardiotoxic, certain drugs are neurotoxic. So what kind of drugs the patient is on, you have to know the neurotoxicity can be there, and you are there to treat that neurotoxicity, not treat, but manage. With the neurotoxicity, the patient cannot balance on his foot. It is peripheral, sort of peripheral neuropathy that develops. Now you can desensitize that. You can add on some balance training exercises to move on with the stuff. I'm sorry with that. Yes. Okay. Then the radiation therapy, yes, radiation fibrosis, the physiotherapy plays a very important role because we are there to free the joint irrespective of the changes the radiation beam is making. But be precautious with the skin changes. The skin becomes dry and cracks sometimes. So you may lead to an injury because of the tissue stretch. Be gentle in this, be gentle in this. Sorry for that. Okay. Prosthesis, yes, a lot of prostheses are available in the market, and prescribing a prosthesis to a breast cancer survivor is mandatory, not just because it is of a cosmetic, the external prosthesis I'm talking about, not just because it's not just because of the cosmetological appearance of the women, but it is because it helps in maintaining a proper posture. One side there is breast, and on the other side there is no breast. So it can lead to a little bit spinal changes, a little bit weight things and all. So there are a lot of prostheses available in the market, which is one is the silicone based prosthesis. Another one is very, very good. This is the Knitted Knockers India provides this prosthesis free of cost all over India. If any one of the survivor wants this, you can just contact us and we can provide this. Knitted Knockers India is absolutely free of cost. These are made of a cotton a specified cotton, and this is knitted or woven sort of thing. Specifically, it's available in various sizes, and the Knitted Knockers India is run by Dr. Rohini Patil. She is one of the gynecologists, and she provides everything free of cost. So very important at the end is educating the patients for the symptoms. As soon as you get something, come to us. That begins from the pre-operative level: heaviness, pains, tightness, restrictions. The earlier they will approach, the better will be we can be giving the treatment, and the earlier will be the recovery from them. So educate every of your patient. We need to educate all our patients during, after surgery, before surgery, during rehab, every time. Yes, rehabilitation considerations for breast cancer related lymphedema are different, because we cannot treat breast cancer related lymphedema with electrotherapy. Complete decongestive therapy is the gold standard, which includes MLD, compression bandaging, decongestive exercises, and a full schedule of that. One more thing, what my physios usually ask me is pneumatic compression pump. A lot of people think that if we put our hand into the pneumatic compression pump, our lymphedema will be gone. But the pneumatic compression pump, it needs to be a 12-chamber pneumatic compression pump, well calibrated with an individual pressure adjustments in that. And it is usually for the home purpose if the patient wants to buy it. And mostly we give it in the second phase of breast cancer related lymphedema. And most of the people, they don't even need pneumatic compression pumps. Deep oscillatory device is yet another device which is approved by the Lymphology Association, and I do use this device in some of my cases. But again, complete decongestive therapy remains the gold standard treatment. Even for this, patient education and screening for lymphedema after breast cancer is very important. Manual lymphatic drainage is highly recommended after any kind of orthopedic mobilizations, manipulations, or stretching exercises you do. And in stage 2 and above, if you find that there are stages of lymphedema, if you find that the lymphedema is on the second stage, it is mandatory to have complete decongestive therapy along with the conventional physiotherapy. Now, lymphedema is altogether a big topic. I will need another webinar possibly to explain that, but I try to cover as much as possible. So coming to the end and summarize everything is knowing what not to do as a physiotherapist is more important. We know what to do, but what not to do is very important for us to know. Then the second one is like cancer surgeries are different than other surgeries. You know, the cancer surgeries are really different. Excuse me. Yeah, so the cancer surgeries, they are different than other orthopedic surgeries or other general surgeries, because in other general surgeries, they don't remove the lymph nodes. Here, they remove the lymph nodes. Cancer treatments are different than other treatments. There is a lot more psychological impacts with the cancer treatment than any other treatment. And so the physiotherapy consideration and treatments are very different with the oncology population. Lymphedema is not good. It needs longer management. So increasing the risk of lymphedema, but because of us, is not a good idea. Applying heat, applying cold to that area, any kind of injectables. These days, people took vaccine and they developed lymphedema because they were unaware that they should not take any kind of injectable on this side. I have a patient coming to me after she developed breast cancer 20 years back, 21 years back, and there was no lymphedema. She took the vaccine on the same affected side and she developed a huge lymphedema after 21 years. That was a causative factor for us. So it's every time important to make bombard on the patient's mind that no trauma on that hand, no trauma on that hand. Yes, timely physiotherapy is a boon in patient recovery, and physiotherapy plays a very, very important role in oncology rehabilitation, especially with breast cancer rehabilitation. Physiotherapy is very, very, very important and very much important, I would say. And thank you so much for your for listening to me and for your patience. Are there any questions so that we can take on with it? Over to the organizers.
Yeah, just
Yes, ma'am. Ma'am, is there any relation between vitamin D deficiency and breast cancer?
Okay, this is a very good question, because a lot of researchers have shown that vitamin D just doesn't affect the bones, but every organ of your body needs vitamin D for a proper functioning. but there is no very few data, very less and contradictory data whether vitamin D is the only factor responsible for developing breast cancer related lymphedema. But yes, an average amount of vitamin D is important for our generalized well-being, not just the bone thing, but the generalized well-being. Every organ of our body needs vitamin D. Any more questions?
Any other questions from the audience?
Ma'am, will spine affected during and after breast cancer?
Spine, you're saying? Spine?
Yes, ma'am. Spine.
Yes. See, breast cancer has the metastasis of breast cancer first and foremost goes to the other breast, and the second most common is the back, the thoracic spine. So that is the very common region where they develop metastasis. So when you're dealing with some kind of oncology patient, you need to make sure that she doesn't have metastasis. Can develop anytime. It's not like after 2 years, 3 years. She's complaining of back pain there, you need to make sure that she's not having a metastasis in that area. So we always recommend a scan or PET scan or a good assessment for that, whether we don't need something which is active in this. And spine is otherwise also affected because the breast surgery has an impact on the other muscles which are related to spine. So it's not the spine, but the paraspinal muscles we need to take care, especially the cervical and the thoracic spine. Yes.
Dr. Devyani, can you just brief in tell us about the difference between the lymphatic drainage and soft tissue manipulation techniques like we generally do it, like
Yes,
friction
yes.
massage and everything? Yeah.
Yes, sure. Okay, so the thing what I'm saying is like soft tissue techniques are different. Those include the C-reax technique, what we use for scar tissue mobilization. Those are soft tissue techniques. Myofascial release is different. See, myofascial release also increases the blood flow, so it is different. And when we come to a specific what you call manual lymphatic drainage, it is a very smooth movement, like a feather touch. We have to move the fluid towards the available lymph nodes. There are lymphatic channels throughout our body. So you have to move the fluid in a very subtle way because this lymph, which is there, it is not at the deeper side, it is just below the skin. It is just below the skin. You know, if you have to drain just below the skin, if you're pressing more or doing more pressures like we do in other massage techniques, then you will create a lot of fibrosis there. It won't drain the fluid, but it will lead to the hardening of the tissue and making the lymphatic drainage more difficult in a longer go. I've seen patients, a lot of Raj has been done, a lot of soft tissue mobilizations have been done, and they develop fibrosis. That lymphatic tissue, it develops fibrosis, which is really difficult to manage. So no massage. Lymphatic drainage, manual lymphatic drainage is a very subtle and a very rhythmic movement. Because of the structure of lymphatics, it is different than our veins and our arteries, arterioles and venules. The lymphatic is like budded sort of thing. So your movements needs to be like pumping movements, not as continuous straight movement with a very light pressure, feather touch, feather touch. It is actually feather touch.
Okay, there are some questions from the audience in the chat box. They want some details regarding the prosthesis that you have mentioned.
Yeah. Okay, the process is what I was telling about. The silicone prostheses are available in various places. If someone is asking me about the knitted knockers prostheses, yes, those are cotton fabric prostheses. I can post the number of knitted knockers here, or they can contact me. I can give the number of knitted knockers. And if they ask for the prostheses, it is delivered to their doorstep free of cost. So you just need to call on that number if someone is asking for the thing. Yeah, yes, someone is asking for that. Yes, I'll do that. I'll do that. You can take down my number from this. Please note down my number, and you can ask me for anyone wants that. You can ask me directly from that number as well. Please note down my number. Those have not have 8806 777717. I'll post it in the chat box. My mobile is not with me, so I'll image, otherwise I would have shared the number of knitted knockers. I'm typing my number here.
And there's a question. At what time we should go for the massage in mastectomy? From what time we should go in fibrosis cases?
No massage, please. No massage in any of this thing.
We
No
have to go for
massage.
lymphatic drainage technique, right?
Yes, no massage, no massage. That we have to take out of our mind. Massage is different. Manual lymphatic drainage is different, because in manual lymphatic drainage there is no effleurage, no petrissage, nothing like that. What is in the massage? Nowhere massage in any of the onco patients on the affected side. Yes, anywhere else in the body you can do, but not on the affected side. Now, when should we start manual lymphatic drainage? You can start the manual lymphatic drainage immediately after the surgery if you feel that the heaviness is there. During radiation therapy, yes, you can do manual lymphatic drainage, but make sure that there is no metastasis there. Otherwise, you will spread the metastasis because of the manual lymphatic drainage. Make sure that the metastasis is not there. So you have to do certain scans are available, or you can see the patient's notes from the hospital she's taking treatment from. It mentions whether it is metastasized to somewhere or not. It is very important.
Okay. And after how many months of mastectomy we can give the recommended prosthesis to the patient?
Okay. The recommended prosthesis, the silicone prosthesis, it doesn't absorb sweat, so it becomes a little sweaty inside the tissue. And but there are some caps, like there are the inside the braziers what the patient use. There is a packet which absorbs a lot of sweat. These kind of prostheses or even can be used after the tissue is completely healed. I mean, the surgical site is completely healed, and there is a less of sensitivity, because the silicone breast prosthesis sometimes irritate the skin also. But if you are talking about the knitted knockers, we prescribe the knitted knocker prosthesis immediately after the sutures are healed and there is no scab over there. They can use that prosthesis anytime after that.
And after recovery of breast cancer, is there any chances? Obviously, there will be chances that will affect the future pregnancy or the lactating hormones. How
Yes.
it can affect? Yeah.
Okay. So if the patient is on, there are various type of breast cancers. Some are hormone receptors, some are triple negative. So according to that, the chemotherapy and post-treatment, post-chemotherapy treatment, hormonal treatment will be prescribed to that particular female, and she may not be able to conceive for certain months until the treatment is on. For if the female is planning to conceive, then she should visit her oncologist and make him know that she wants to conceive. And if the drug and other things if he feels that he can stop certain drugs or modify certain drugs, then the patient can conceive. But this is, there is some, it's all dependent on the stage of cancer and the drugs that are prescribed. For lactation, during chemotherapy, lactation is obviously not recommended, because those drugs are go into the milk that is fed to the baby. But again, if they are on certain hormones, then you have to consider your gynecologist, your oncologist, before you go for the lactation of the baby. Lot of drugs are there, lot of drugs. Some drugs are allowed, some are not allowed. Depends on what type of cancer the patient is having. It's triple negative, it's ERPR positive, or it's ductal cancer, whatever. So it's a very big thing, and it should be considered with the oncologist, the gynecologist, and everyone. It's their department.
The new adjuvant therapy is there that will reduce the side effects of chemo also.
No, the neoadjuvant therapy is the neo words is just the same chemotherapy which is given before the surgery to shrink that tissue, and then they operate it a lot of time. It's the same chemotherapy drugs. They don't, it's not that afterwards it will help in less of the symptoms or so. It's like if the neoadjuvant therapy is given in only certain cases when the tumor is inaccessible or the tumor is a huge to operate, then they'll give the neoadjuvant therapy to shrink the tumor size, and then they will operate it, and then again chemotherapy. It's like that. So it's not that the side effects will be less or more. The side effects will remain the same, even before, even after. Only chemotherapy, no surgery, even the same. Anything else?
Any other questions from the audience?
Anyone needs any kind of help for rehabilitating an oncology case, you can freely contact me, no problem. I'm always happy to help you on phone as well.
Okay, thank you so much for the wonderful session, ma'am. And it
Thank
was
you so
lovely
much, Dr.
having you
Sonam,
here.
for this opportunity. I'm very thankful for your institution, because they have made a point to utilize this proper month and awareness thing to
Yes.
educate their own students. That is very important. This is a very important thing, and a lot of things are not covered in our books for
Yes.
oncology physiotherapy.
Exactly. For oncology, it has not been covered yet. So it's a good
Yes.
part. And I would really thank you. You have come across and you have given us your knowledge and experience. And it was lovely having you here, ma'am. Thank you so much for your time. Himanshi, can you please come in?
Yes, ma'am. Thank you very much, ma'am, for enlightening us today. It was a pleasure to have you with us. Thank you for such a knowledgeable session. This will surely help us in developing our skills towards role of physiotherapy in breast cancer rehabilitation. Thank you, ma'am.
Thank you so much.
I think any other questions, or we can end the session? I think we can write down. Okay. Thank you so much, ma'am, on the wonderful time. Thank you.
Thank you.